questions right now. So what I am going to do is I am going to introduce Kat. If you've got any questions during her presentation, raise your hand, and then when Kat is done, then we can open it up one more time for questions for either one of them. Okay, so welcome, Kat. Right now she is the Emergency Response Planner with the Missouri Health Department, and this year will mark her 7th year in this position. Her county is one of the Kansas City's Readiness Initiative jurisdictions, which requires them to have plans for mass prophylaxis of anthrax per CDC requirements. She received her bachelor's from Kansas State University in 2003 in food science and has almost 7 years of regulatory background working for the state of Kansas. She is a registered environmental health specialist as well as part of a newly formed Public Health Emergency Preparedness Board for the state of Missouri to address gaps and needs for public health preparedness. She is one of the planners who volunteered to represent Region A and is also planning a mass fatality tabletop exercise addressing death surge as a result of smallpox release. So, Kat, we look forward to hearing from you and your talk on antibiotic resistance.
Thanks, Jen. Can you guys hear me?
Yes, we can.
Okay, cool. Like Jen said, my name's Kat Robnett. I'm actually the emergency response planner over here in Platte County, Missouri, which is part of the Kansas City Metro. This presentation is going to be, actually for a lot of you, if you're not going to the international, don't quote me on this, but it's the Disaster Medicine Conference down in St. Martin this week. I'm actually presenting down there, and this slideshow is what I'm going to use to talk about my abstract. So I'm saving you guys all that trip and travel and planning headache. So my presentation is about the impacts of antibiotic resistance and with regard to public health emergencies, including hurricanes, and potential mitigation strategies that we can use or implement to help reduce this from becoming an even worse problem. So just a quick overview of antibiotic resistance. Again, we hear this term a lot. It just means that the bacteria are being able to develop the ability to overcome and supersede what the antibiotics we have currently can do. So you hear a lot about the penicillins. A lot of these bacteria aren't penicillin susceptible anymore. Or you hear about MRSA, the methicillin-resistant Staph aureus strain that really likes to pop up in public places like gymnasiums and locker rooms. So multiple strains of these bacteria are resistant or becoming resistant to the first and second line antibiotics, which is not good because that third and fourth line of antibiotics are a lot harsher on the human body, and some of them they're just not as effective as the first and second lines are that everyone seems to prescribe more and more of. So just recently, the World Health Organization did recognize the antibiotic resistance as one of the top 10 public health threats. So it's right up there with obesity, pollution, chronic diseases. And of course, you've also heard about the other strains of bacteria like the gonorrhea-resistant strain that's now unfortunately rearing its ugly head. Recent natural disasters have illustrated these challenges with treatments for patients who had soft and skin tissue injuries, which were the most common injuries in disasters like hurricanes, floods, and the tsunami of 2004. But don't worry, there are rapid detection technologies that are commercially available, and they must be incorporated into these planning and response tactics if we are to stay ahead or at least keep the playing field from becoming greater for those bacteria. So our first case is Hurricane Harvey, which everyone heard of. It hit the Houston area. The students at Rice University and Virginia Tech did a study on some floodwaters from several different sites within the Houston metro. And these samples identified abundances of what they call the SUL1 gene and the INTL1 gene in various water samples. This is not good because this can be a severe or significant health threat to folks who might be wanting to clean up their houses or their businesses after a flood event, because if these bacteria are present in that environment, and say you get an insect bite or you have an open wound or you get cut or scratched, you've just created a gateway for those bacteria to get into your body and possibly inflict very serious disease. Potential sources were identified. Wastewater treatment plants were one of the biggest suspects because a lot of them were inundated during the intense rainfall of Hurricane Harvey. So a lot of them either had released partially treated or untreated sewage into the rivers and into the bayous, which of course we all know untreated wastewater is a viable source of fecal bacteria and fecal material. So additionally, other findings included families of bacteria that contained Aeromonas, Klebsiella, Legionella, and Salmonella. So it wasn't just these specific fecal indicators, but there were other families of bacteria that were present in these samples. Also, additional assessments conducted revealed that E. coli levels were 100 times higher than what the EPA established as a threshold for safe recreational waters. This is not good because some of these bacteria were found to have lasted for months after the rains left and everything dried out. A second study of water samples they obtained from the Guadalupe River also revealed high levels of E. coli and enterococci located in the highest impact sections of the river. So the sections of this river that were hit the hardest had the highest concentrations of these bacteria. Excuse me. It was also noted that some of these species had elevated levels for up to 3 months, as I had previously stated. This, again, can pose a public health threat for folks who are just trying to clean their houses, their businesses, and their properties. So, in short, you know, the risk was still there, even though the waters had receded. And it's also worth mentioning, note, that there were 3 documented cases of necrotizing fasciitis in Texas. 2 of those cases were fatal in folks. And the one case that was survived, it was an EMT who got a mosquito bite, which they believed was where the bacteria was introduced into his bloodstream. So it's not just a scratch or a wound, but you could get bit by a mosquito and not know it until your arm starts getting bright red and it's starting to look like the flesh is being eaten away. Again, that's why it's so important that when these folks are cleaning up that they just have to make sure that they keep open wounds covered, wearing the right personal protective equipment in this case. The next stop is Hurricane Florence, which we all know hit the Carolinas. This was the one that everybody in Charleston was freaking out about, and they were taking down the big cow statue as a precaution. Well, North Carolina took the brunt, and the biggest culprit were these large commercially operated hog farms, which North Carolina is well known for. And the problem with that is that these lagoons were susceptible to floodwaters. And unfortunately, during that time, 6 had structural damage and 33 were reported to have overflowing due to the floodwaters and the torrential rainfall, which of course allowed for bacteria that was present in these waters to be released into the environment. I noted that also during Hurricane Floyd, which was 20 years ago actually, they experienced similar problems in North Carolina regarding these large operational hog farms. Apparently we didn't learn our lesson. So what happened was that they had 46 operations that had overflow from these lagoons. But even then, up to a decade later, fecal bacteria concentrations were still high and downstream from those sites. So you're talking anywhere between 40% of the exceeded state and federal water guidelines for E. coli. Or if you're a numbers person, we're talking 140 million or 10,400 colony forming units per 100 milliliters of water, which is pretty high if you're one of those that seems to know the statistics and you understand what the thresholds are. I'm not a threshold understanding kind of person. I just know these numbers are not good. Unfortunately, you know, when you're lasting up to a decade, that's just additional potential for problems to arise. So, and to compound this situation, I've discovered that there is a lack of significant oversight, if any, on how these impacts of the lagoons and public health correlate. So there's no government agency at the local or state or federal level that really has any type of literature or documentation that specifically identifies lagoons of commercial hog farms and, well, how could these be a potential problem to human health in the event of a disaster or just perhaps even in general? So again, this is just another potential issue for letting these bacteria into the environment. And also, in my review of literature, I noticed that during this time with Hurricane Florence, that there was a rare bacteria called Shawonella. If I mispronounce this, please forgive me. Putrefaciens was reported post-Hurricane Florence. For those of you that don't know, this is actually a bacteria that's common in multiple water sources, but it's a rare bacteria. You don't see it in the United States on a frequent level, but it is a result of a soft tissue or skin infection becoming infected or exposed from floodwaters in which this bacteria is present. So, of course, multiple water sources can be your fresh water, your brackish water. This guy, he can kind of go wherever he wants as long as there's an adequate water source. So, again, this is an emerging infectious bacteria or disease that is just something to keep an eye on when thinking about potential impacts on the public health. I also went and looked to Hurricanes Maria and Irene. I'm kind of grasping back with Irene, and Maria is a little more recent, but I just noted that with Maria, they had that outbreak of leptospiriosis in Puerto Rico. Again, this is contaminated soil or water that is the source. And with Puerto Rico, their infrastructure was so inadequate to begin with that after the hurricane rolled through, whatever water infrastructure they had was gone. So they were resorting to having to collect water like this nice lady in this picture here through whatever, pipes or systems that they could establish. And a lot of folks were doing laundry in questionable creeks and streams, which had been impacted by these floodwaters and storm surges. They said that with this outbreak with Maria, there were approximately 57 documented cases, although there are suspicions that the number is much higher because the medical infrastructure was also not adequate in terms of keeping track of deaths, the mortality, and the morbidity. But they did document 26 fatalities from this disease. Again, some suspect that the numbers are probably going to be higher. Hurricane Irene. Hurricane Irene was another one that rolled through the United States back in 2011. And there was a case of, this is another rare one that you really don't hear about. I'm not going to try to pronounce it because I'm afraid I'm going to chop it up. However, I will tell you this much, that the case in question was an 81-year-old patient who was cleaning up floodwater from the basement of their home. However, it is noted that this person has a history of chronic health conditions, which their immune system and their body was already immunocompetent to begin with. But as they did further testing on this individual, the right leg had a lesion, was swabbed, and they found presence of heavy streptococcus and a few enterobacter readings. So this was what they call a polymicrobial infection, meaning there was more than one bacteria involved. And this is the type of infection that's going to be a significant issue when we're trying to get treatment and medical care for patients in these similar disasters. The strain was susceptible to all of the antibiotics, but I will note in my readings that there was one unrelated case of a patient who had an acute myeloid leukemia, and this strain was actually resistant to third-generation cephalosporins. So, unfortunately, the resistance is there, but these examples are identifying that this is becoming a potential problem, and it is becoming a bigger problem, as we'll see in the next few slides. Hurricane Katrina. Believe it or not, I don't know if anybody was keeping track of the public health issues with Hurricane Katrina, but at a mega shelter in Texas, they had 30 reported cases of MRSA. For those of you that don't know, MRSA is methicillin-resistant Staphylococcus aureus. They call it the superbug because, well, unfortunately, he's super resistant. But again, this was identified just out of one mega shelter, and 24 cases of Vibrio were identified, 2 different subspecies. Luckily, there was no cholera, which we all know is bad news. So They looked at this, and these were actually wound infections, but there were 2 fatalities from it. It doesn't say if the patients were immunocompromised or immunocompetent, but unfortunately with the Vibrio family, they do tend to like that warm, brackish water. The tinea corpus, there was 17 cases. Now, these were reported in Mississippi among military personnel who were helping with the evacuation efforts before Katrina made the landfall. Now, this is a type of skin ailment, which was caused from exposure to, again, the environment and the waters and the rainfall, which, which of course these folks were exposed to, because when you're trying to get so many millions of people out of the way of an oncoming storm, unfortunately they were exposed to this specific type of infection. The big one that I'm going to go over is the 2004 tsunami. Now, everybody's heard of the 2004 tsunami, but this has also got the most documentation about polymicrobial infections and antibiotic resistant strains. Since it was 15 years ago, there's been a lot more time between now and when this happened to get more information regarding these polymicrobial infections. Now, it also should be documented that 515 of 770 patients had recorded skin and soft tissue infections, which of course, this is grouped together. This isn't broken down. And the majority of these injuries were exposures to water and debris. Now, exposure to water also included inhalation of water droplets from the oncoming surge and the receding waters. Of course, the majority were the skin and soft tissue infections from, and this exposure to these different materials included mud, sand, sea vegetation, land vegetation, trash, refuse, and then also whatever else was in that water as the wave made its way on shore. So there was a lot of different areas, a lot of different chances of exposure to multiple unknown bacteria, both marine and freshwater. So it's kind of interesting to see how this played out in this part of the world after such a large event. Now, I also want to note that some patients were diagnosed with necrotizing pneumonia, and they did not respond to the standard broad-spectrum antibiotics. So basically what happened was they go in, they start a wide range of different antibiotics because we don't know what's going on yet. We don't have any resources coming in to help us say, okay, well, this person has this bacteria, because everything's been pretty much been washed away. So it should also be worth noting that some of these folks also may have had fungal infections in concurrence with these polymicrobial infections, which would have made treatment and diagnosis a lot more difficult, because again, some of these fungal pathogens also may have been resistant to whatever medical treatment or whatever equivalent of antibiotic was out there. And the majority of these findings also revealed that the aquatic associated wounds were also, it was a more of gram negative than gram positive. So, which I found interesting, because it seems that the gram negative bacteria were a lot more abundant in these infections than, say, gram positive. I'm not sure about the reasoning behind that. That wasn't part of my study or my research on this project. So maybe in the future, maybe as part of a capstone, maybe I can do some more literature review to find out what might have been an explanation behind that. Excuse me. So on the left are 2 different types, and I'm sorry that I did not write down the names, but these were 2 of the bacteria that seem to be apparent in a lot of these SSTIs. A lot of these marine bacteria were present, had resistance to the 1st and 2nd generation penicillins and cephalosporins. So you go in with your 1st and 2nd string, they're not going to work. So that leaves us with what? The 3rd and 4th strings. And a lot of bacteria were identified. There were multiple. So I'm going to give you a couple names, and again, forgive me if I chop these up. I'm really terrible at pronouncing names, but I think a lot of you might be able to understand what I'm trying to say. The Aromonas species, the Burkholderia Pseudomonas species, Acantobacter baumannii, Stenotrophomonas species, E. coli, Klebsiella vibrio, extended spectrum beta lactamase producing strains. Try saying that 3 times. Staph aureus, MRSA. We had Mycobacterium marinum, Mycobacterium chelinae, Mycobacterium fortuitum, and Mycobacterium abscessus. That's a lot of different bacteria. They also found A. hydrophilia, which was resistant to the penicillins and the first generation cephalosporins. Schoenella species were most sensitive to the broad range. However, the algae subspecies were resistant to penicillins and again the first and second generation cephalosporins. So again, you can see there was a plethora of bacteria present in these wound cultures to identify that we weren't dealing with just maybe 1 or 2 strains, but we were dealing with a spectrum of marine and freshwater, because this tsunami really stirred a lot of stuff up. And the infrastructure with parts of that world were not as adequate as, say, the developed world. And also just trying to be able to get in there and get people treated, get people out, get people triaged. That also impacted the amount of time to get in and start any kind of treatment, because these folks, the main concern was getting people out, getting people initially triaged, and trying to get them to the nearest hospital. So of course there was time for these bacteria to get in there and colonize in these people, in their infections, which made it that just much more difficult for professionals and for medical responders to be able to get people, to get them back on the road to recovery. I found 2 cases that demonstrate how extremely difficult it was to treat these cases. These were 2 tourists. And the thing is that a lot of the medical information from Europe was a little bit more available than, say, from Southeast Asia, because Europe, a lot of these tourists were actually transported back to their home countries for further medical treatment, which of course they had a higher standard of infrastructure. So our first case was a 59-year-old patient who they had bronchial infections, and this was because they were inhaling water droplets from that tsunami and from those flood waters, because they got swept up in it. So I mean, they're breathing all of this in, which of course for this individual, they actually had cultures done and they identified the Acantobacter baumannii, which is resistant to all penicillins, cephalosporins, aminoglycosides, and the trimethoprim okay, let's just say that it was resistant to quite a few of the different antibiotics that were available at the time. And they also had E. coli in their lungs. So again, that's some fecal going on. The next patient was a 51-year-old who had soft tissue infections. And this individual, again, they did cultures. They had the Acantobacter, which this strain was resistant to all the penicillins, the cephalosporins, the aminoglycosides, the fluoroquinolones, and the trimethoprim sulfamethoxyl, and it was only sensitive to 1 antibiotic, and that was colistin, which is your last line of defense. The absolute last thing any doctor wants to prescribe to somebody who is not responding to any of the other antibiotics. And the colistin actually can be very rough on the human body. I mean, the horror stories alone from it is just not, kind of makes you think, ow, this is how serious this problem is. And I noted that the mycobacterium was present. This was done 3 months later. They did another culture on this patient because this person was having difficulties healing. The wounds weren't healing like they should have. So I wanted to note that this Mycobacterium, this species, it's actually among the most resistant of the family, and the treatments, the requirement is it has to be done on a sensitivity test result. So you basically have to do the antibiotic sensitivity test to determine which antibiotic or antibiotics can you use to treat this specific bacteria. So again, not a good situation here when you have multiple strains of multi-resistant bacteria compounded with a very large wide-scale disaster and multiple casualties and injuries. But there is hope. As I said, there are rapid detection technologies which are now commercially available, and I've been to their websites. I kind of did some reading on them. So there's a few that I highlighted because these are the ones that seem to stick out that were a little bit more well-known. The first one, this is made by a company called Cepheid. It's out of Europe. And they have two different kind of assays that use the cartridge, which was just pictured in the previous slide. And these are assays that look for carbapenemase genes. And I wanted to know, for those of you that don't know what the little lower cases mean, I went ahead and I looked them up just to clarify. And I tried to find the difference between the two different assays, and I really couldn't find a specific difference. But according to this, okay, so we'll start with the MDRO assay. The KPC is for the Klebsiella pneumonia carbapenemase. IMP, or the NDM, is the New Delhi metallo beta lactamase. This is this was discovered from someone who had been to India, and I think it was 2008. And the VIM is the Verona integrin mediated metallo beta lactamase. So these are the genes that this specific assay is looking for. And the CARBA assay, again, it looks for the carbapenemase genes. And for them, IMP-1, it actually means imipenem. The KPC I just explained. NDM, same, it's the New Delhi gene. The OXA is the beta lactamase, which is present in the Klebsiella pneumoniae. And that's the only difference, is that the CARBA actually looks for two more genes in addition to what the MDRO looks for. So I guess it just depends on what you might suspect or what you're specifically looking for. Film array, which is done by BioFire Diagnostics. It's a company here out of Salt Lake City, Utah. And similar that they do is what's an identification panel. And it too has certain resistance genes that it looks for. And again, it's the, I believe the VAN is the vancomycin. KPC again is the Klebsiella pneumoniae. And the BLA, and again, it looks for, and it wanted to note that it looks for gram-negative cultures, but I don't think, I'm not sure why it had that noted, but this also uses a panel. So you take the sample, which is, in this case, would be blood, and you put it through and you run it through the panel. And according to what Film Array, the website was telling me, is that this will take about, it says it takes up to about, I think at most an hour. The expert takes approximately 48 minutes to get results. So you can see how quickly this is, how quickly you can get a result from these technologies. And not to mention they're portable, and you can put them into something of like a Pelican case or their own travel cases, and they can go in the cargo hold of an airplane and be ready to go as long as you have a power source. The next one I wanted to show is called, it's EasyPlex. It's by Amplex Diagnostics. 20 to 30 minutes for results. Again, it has two kits for superbugs. Again, just a little, there's really not a lot of differentiation between the two. I believe according to their website, they did, okay, so the only difference between Superbug Complete Kit A and B is that there is a difference. There's like one different resistance gene that B looks for versus A. And again, the resistance genes that they look for were similar to what the Expert Carb, Expert Carba RSA and the MDRO assays look for. Again, this is a little smaller, a little more portable, but that's not to say that the other two technologies wouldn't be viable either. Mitigation strategies. So one of our biggest issues that we have with mitigation strategies is knowing what we need. What are we getting into? So health-related education is going to be a big one. Again, we do this every day. When you go to the bathroom, you wash your hands. We saw with Ebola. They talked about sanitation and hygiene. They went out and did a huge education campaign to the communities that were impacted by the outbreak. How do we go about being able to, educate people, but at the same time, not instill any panic or cause any additional fear? So hygiene and sanitation is a big one. Again, in a disaster setting like the 2004 tsunami, that's going to be a challenge, but that doesn't mean it can't be done. Personal protective equipment use. When you clean out your houses, if you got a flood, you just get out of a hurricane, a flood, a tornado, appropriate personal protective equipment. It could be something as simple as a pair of coveralls, making sure that you're wearing heavy-duty long gloves that go up to your elbows, using the right type of respirator, wearing safety goggles or safety glasses to prevent splashback, to cover your wounds before you go, mucking around through a flooded basement. Common sense stuff that we already know about, but just making sure that we iterate it to those people who might be out in those conditions. Early medical management, this is going to be another big key area. Successful early wound management, which included aggressive debridement and the vacuum assisted closure. So basically getting people into facilities where they can get in, they can flush these wounds, they can clean out the debris that might be present, getting access to these resources that will help close these wounds with a little more efficiency than, say, just a regular pair of clamps, stitches, and sutura. Because that reduces the amount of time that the bacteria is going to have. So the quicker you get in, the less time bacteria and the less chance they're going to have to get a hold. Another one, isolating patients from these areas until they can determine what if any bacteria has colonized. For example, having a triage area. People who are coming from an impacted area, separate them, get them tested. Once the tests come back and identify if they're good or if they've got an infection or if they're colonized, then they can go to the next step that might be set up, which is maybe treatment, maybe surgery, or it may be something else. This prevents the cross-contamination and introduction of these pathogens into additional treatment areas where it may be a clean area, a clean room, for example. I did note that for the Acantobacter, cleansing and environmental disinfection of the room and every surface within would be one tactic to help mitigate the introduction or prevent the spread of this bacteria from that room to maybe other rooms. Because unfortunately, humans are a big carrier of a lot of these pathogens and they may not know it. So I'll bring up another example. If you remember the KPC outbreak at the National Institute of Health Hospital, it wasn't so much the sanitation, it was the fact that people were carriers. So again, just thinking of preventing that cross-contamination, reducing only certain personnel are going to be allowed to go into these areas. And then having, maybe even screening those folks, make sure they're not colonizing. They're not a colonizer of a bacteria in question. It just depends on what the strategy is. What are we looking at? The rapid provision of potable water and sanitation facilities. Very, very critical. You can't clean wounds if you don't have a clean water source and you don't have a safe environment to do it in. With the tsunami, again, widespread damage. There was really no hospital facilities in the impacted areas. So there was no way for people to properly be able to start wound management with the flushing and the lancing of these soft tissue and skin infections. So people were basically being sent to these hospitals with pre-closed wounds that still had debris in them, and the bacteria, had a way to proliferate. So this goes up to the next point. Understanding what might be we see already there. What's going to be endemic? What might be endemic to those regions to begin with? This should be part of any current or disease outbreak that may be ongoing. Were they dealing with an outbreak of something before the disaster? It's important to understand that if you know what you're getting into, not only do we have these bacteria, but They got an outbreak of salmonella, so we got to be careful. We got to look for salmonella. Is it resistant to antibiotics? So kind of like know thy enemy type situation. Again, and then some folks even, and of course, I'm not a medical doctor, I'm not a medical expert, but this was something that got brought up in a couple of different pieces of literature. Some recommendations to just kickstart broad spectrum treatment to prevent the necrotizing infections, because again, those are pretty aggressive, they're pretty nasty. I've seen photos of these wounds. The gentleman who survived in Texas, the EMS personnel, his arm was red, swollen. It was just not a pretty sight. So, again, I think it just depends on the situation, but these are actually some pretty viable mitigation strategies to help in this fight, since obviously we are not, the way we're going, we're losing the war on antibiotics, unfortunately. So let's see if we can find some ways to slow that down. So basically, again, kind of a summary. I just wanted to reiterate that, yes, specific genes were found in this post-Harvey flooding. We had rare disease occurrences post-IRENE and Florence, respectively. So again, not only are we dealing with antibiotic resistance, but we have emerging infectious diseases that we need to have on our radar. And this 2004 tsunami just really ripped the lid off of all of healthcare challenges in a large-scale disaster, especially with a poor infrastructure, and it was a large tourist spot. So you're dealing with a cross-section of people, infrastructure, resources, and environment. But again, these rapid detection technologies, these can be easily packed. You can take them with you. You can set up shop. You can start running samples and you start getting results within an hour tops. So this would allow for doctors and for health providers to be able to match the appropriate treatment to the appropriate patient, which is what the target is. So if we can implement and incorporate these into future planning, future response, then perhaps we can get somewhat gain some ground against this antibiotic resistance. Again, I want to thank everyone for giving us a chance and giving me a chance to speak. I really am sorry that I chopped some of the words and some of the species names of these bacteria, but I'm not a medical expert. I'm not a microbiologist, but my goal was to let the slides really speak for themselves and just to show that this is something that fascinates me. I do believe that we can, gain ground against antibiotic resistance. We just have to observe good stewardship, even in times of disaster. And just, it's going to be a progress. It's going to take time. And I think it's going to be a very lengthy process, but it is doable. We just have to learn from what's happened so far in the past. Again, thank you, everyone. Sorry if I did chop the words up, but this is a topic that is very fascinating, and I just find very frightening, to say the least. And that's all I have.
Thank you so much. That was another really great presentation. Both of them were very, very interesting on their own, but also it was really great to be able to see the work that our students are doing and to see the different interests that you guys have. So thank you both very much. And I know that we do have at least a couple questions. So I'm going to turn it over to Gene right now because I know he had at least one.
Excuse me.
Okay. Hey, Jen, can you hear me now?
Yes.
Good. Yeah, just again, great presentations, both Joan and Kat. Thank you very much. I'm really proud to be a part of this program and hear you all presenting. I'll try to, this sort of applies to both, but I think I'm going to direct it more towards Joan since her hypothesis really had to do with